because we have less time. Because we have less time here, which is around 30 to 40 minutes. I would try to cover all the aspects of surgical and prosthetic implantology. I'll simplify it into a basic summary and then try to give information to everyone who is there present. I also thank everyone who has come here to listen on this subject, which is very important subject when it comes to day-to-day industry now. Without wasting much time, I would like to share the screen with my presentation. I would like to start off with my presentation now. Placement. Let it be a single implant, let it be multiple implants, let it be a full arch or a full mouth implant. We first try to concentrate on one point, which is known as diagnosis. Now, when it comes to diagnosis, it is not simple examination with eye. When the patient comes and sits on a dental chair, we would try to first examine visually and see what is exactly there in the oral cavity, whether it is a single edentulous space, whether we have scope for multiple implants to be placed in the edentulous span that is present, or whether it is a full arch, whether we need to extract teeth and then plan placements of implants into the bone. So this is a simple diagnosis that we concentrate on whenever patient walks in and sits on the dental chair. My suggestion, whenever patient comes and asks for a replacement, and whenever we give an option of implant to the patient, my suggestion is always to have a diagnostic cast with you. Now, why do I say to have a diagnostic cast is, our vision is not monocular, it is binocular. Everyone knows that. Now, when I have a binocular vision, it is impossible to find all the minute details that are present inside the oral cavity with our vision. So if I pour a diagnostic cast, take it in my hand and then see, I would visualize what all is present around the dentulous space, number one. Any minor, supraeruptions of the opposite teeth, any kind of drifting of the teeth which are present next to the dentulous span. All that I can see, I can visualize on the diagnostic cast. And then probably plan accordingly. Before placing implant itself, if I have to correct the drifting of teeth, the adjacent teeth, if I have to correct the supraeruption of the opposite tooth, all these I can plan if I have something in my hand and probably write down in my sheet that, I need to explain to the patient that I might have to correct these either orthodontically or prosthetically, and then probably proceed with the placement of implant. If I don't do these things and just place an implant because I have bone, because I have some space there, then when it comes to the restorative aspect, it becomes extremely difficult. When you have drifted teeth, the restoration that comes in between might be a compromise. If you have a supraerupted tooth opposite, plane would not be even when it comes to the restoration. So all that you plan beforehand itself, tell to the patient that, I might have to do some changes here and then probably place an implant so that your restoration falls into a zone where there is no much stress on the restoration. And finally, when there is no stress on the restoration, the implant prognosis in the bone also becomes good over a period of time. So in diagnosis, my suggestion is to have a diagnostic cast always, and then probably see whether you can place single implant, whether you can place multiple implants, or a full arch or a full mouth as a case. When it comes to treatment planning, and once you have diagnosed the case that that this is falling into this zone, then you have to treat the case prosthetically when it comes to implant. Now, what do I mean by prosthetic planning is, I would like to visualize the final crown before I place an implant. So I would like to have the final prosthesis in mind and then place an implant according to the final prosthesis. This is known as prosthetic placement of an implant. So I would not plan my implant placement surgically. Now, what is surgical planning? When you have dentulous space, you just open up the flap, you visualize the bone and just place implant at the center of the bone where you have bone around the implant. That is surgical planning. But if I do this, is my implant placement falling in a zone where the future prosthesis is according to the opposite tooth? That is what is important finally. Now, if I am placing an implant in 4-6, let's say, I would first visualize how is 1-6, whether my implant is placed into the bone according to that tooth, according to the opposite tooth. That is more important to actually place an implant inside the bone. It is not just a surgical placement. It is not wherever you have bone, you have to place an implant. That might fail because the prosthesis would not be according to the opposite tooth finally. You might be having offset loads again. You might be having a lot of tensile loads on the restoration because the restoration is not according to the opposite tooth. It is not falling into the prosthetic zone. So kindly assess the prosthetic placement first and then place an implant according to the prosthesis, according to the future. So it is always Z to A. It is not A to Z when it comes to the implants. That is one more important thing that you need to understand before you place an implant. In this, CBCT helps a lot. Now, why do I say CBCT helps a lot? Because in CBCT, you will have different dimensions. You will get the bone dimensions. Number one, how much width of bone is present apart from the soft tissue. If not for CBCT, if I just take a diagnostic cast and see, I would not get how much soft tissue is present, how much hard tissue is present. It's a combination on a diagnostic cast. So if I take a CBCT, the soft tissue is eliminated and I would get only the bone measurements. How much width of bone is present, how much height of bone is present, whether the anatomic landmark is closer to the implant that is that is being planned to be placed inside the bone. All these things, the bone density, how is the density of the bone, whether it is D1, D2, D3, D4, whether it is more dense, whether it is less dense, all that I would get from CBCT. So a CBCT is taken before you place an implant in order to get all these things. Now, which view is good in CBCT? You have axial view, you have coronal view, and you have sagittal view. Usually, the sagittal view helps a lot to get the bone width, bone height, bone angulation also, as well as anatomic landmarks, which are nearer to it. So I would suggest if anyone gets a CBCT, you see the sagittal view and then probably plan which implant has to be placed inside the bone, the measurements of implant. I would like everyone to mute their audios because I'm getting a lot of sound here, resound. So if anyone has unmuted, I would request all of you to mute. Now, once a CBCT is taken, you have 3 different types of guides, through which, can I request everyone to mute? Shanuf, can you just take over and mute everyone?
I think, sir, all the microphones are muted, sir.
Because I'm getting a resound here.
Okay.
All right, don't worry. Now, we have different types of guides available. The first guide which is available is known as a surgical guide. It's a simple surgical guide. Now, if you see in the first picture here, you will understand that this guide is made of acrylic. Now, you just take a diagnostic cast and...
Sorry, sir.
I think you have to go to the option of mute all and then mute everyone. Thank you, Shanuf.
Yes, sir.
So this is a simple acrylic stent that is made over a diagnostic cast. According to the opposite teeth, we prepare a stent on the diagnostic cast. And if you see here, there are perforations. So 2 perforations here for 2 implants. These are prosthetic positions according to the opposite teeth. Now we keep this oral cavity and we go through this perforation with the pilot drill and puncture the bone. So here I am just getting the initial position of the implants. I am not getting the bone width here. I am not getting the angulation of implant here. I am not getting the orientation, the depth, nothing. It is just the initial position that I am getting according to the opposite tooth. But I don't know whether I'm going into the bone here, whether I'm perforating the bone here, whether I'm going into the soft tissue, because I've not assessed anything here. It is just a blind procedure where I'm preparing a stent with acrylic, placing it inside the oral cavity and just going and placing implants. So this is not preferred in many cases because we don't know whether we are actually going into the bone. It's just according to the opposite teeth. So we're getting the prosthetic position, but we are not getting the bone position here. So shifting over from here to here, we're getting this CBCT guide. Now, can you see here that we have a sleeve which will determine the exact prosthetic position, the exact bone position also, whether my implant is safe inside the bone according to the dimensions. You'll be getting the position of implant, angulation of implant, depth. Everything is mediated here. Everything is guided here. That's why this is known as a guided CBCT stent. So in case you are a beginner and you are going to place an implant, I would suggest you to take a help of a CBCT guide, take the pilot drill, go and puncture the bone, and then visualize whether you are in the bone and then carry forward, placing the implant. Here also, I would not suggest you to go blindly and place an implant because many times in CBCT also you will have variations. There is something called motion artifact in CBCT. If the patient turns when the CBCT is being taken, you will get artifacts. And according to artifact, if the guide is prepared, you might actually go into a wrong zone, again, inside the bone. So always check with the first drill. When you check with the first drill, you will know whether you are inside the bone, whether there is a lot of bone around an implant which is being placed. Visualize it first and then go ahead with sequential drilling. That is what I would suggest. Now, third picture here is just according to the functional cusp of opposite tooth. Now, when it comes to upper, the palatal is taken as the functional cusp. When it comes to lower, the buccal is taken as the functional cusp. So you visualize the functional cusp where it is exactly falling on the dentulous span on the opposite arch, and then go through, place an implant in that zone. So that becomes the prosthetic position when it comes to. So this needs a little of experience also, because I'm not going guided here. It is a free hand placement. So if you want to have a free hand placement, I would suggest you to do at least few cases, get an experience, and then probably place implant into the prosthetic zone. Till that experience period, I would suggest you, if you are a beginner in implantology, to take a CBCT help. A guided placement is always suggestible. Now, this is placement of an implant. Now, there are a few things that you need to understand whenever the implant is placed in the bone. The first thing is, how do you open up the flap? If you see here, the incision here, which is taken, is not at the midline. It's not at the center. It is slightly lingual to the center. It is slightly lingual to the midline. This is known as a paracrustal incision. Para is slightly away from the midline of the bone. So it's called paracrustal incision. Now, whenever I want to visualize the complete bone, then I would go ahead with paracrustal incision, elevate the flap this way, then visualize the bone and place an implant. So mid-crustal incision, which is at the center, is suggested when you don't want to visualize the complete width of the bone. But paracrustal incision is suggested whenever you want to probably take a lingual side incision and then probably expose the flap buccally to visualize and place implants according to the bone width. The second thing is, after you reflect the flap, you always should have a flat bed of bone. There should not be any spicules. There should not be any undercuts or elevations here on the bone. It has to be a flat bed of bone. So what you do, You take a crestotomy burr, or you can take any burr which is a bone trimming burr, and make the flat bed of bone, which is known as crestotomy. So after you elevate the flap, there is one procedure that you should not miss in most of the cases, which is known as crestotomy. If you have probably a ridge which is a knife edge, that also can be changed into a flat bed of bone with the crestotomy burr. So don't forget to do crestotomy once you elevate the flap. Once you're done with the crestotomy and once the flap is elevated, then you go into the bone and place implants by sequential drilling. Now, what do I mean by sequential drilling? You start with the pilot drill first, then you start increasing the width of the osteotomy. That is sequential. I will not increase the depth here. I'll be increasing only the width. The depth is established with the first drill. Kindly understand this point. Now, when I take the drill inside the bone, the first drill will establish the depth. If I'm placing a 10 mm implant, probably I'll go till 10.5 millimeters and establish the depth with the first drill. The second drill will increase the width. It will not increase the depth. So I'll take a 10 mm drill again, probably increase the width, and then prepare an osteotomy. Whenever you have a density of bone, which is very, very hard, let's say, I would probably take till the last drill. Now, if I'm placing a 4 by 10, let's say, 4 is the width and 10 is the height, is the length. Then I would go till the last drill, probably because it's a very hard bone, increase the width till the last drill and place an implant. If it's a softer bone, let's say it is in between D2 and D3, then I would probably undersize the osteotomy by one size. If I'm going with 4, I would stop probably at 3.2 or 3.6, whichever, according to the system, whichever I'm using. I would undersize and then place an implant, because if I go till 4, then what will happen? The implant size and the osteotomy size would be almost similar. And if they're almost similar, when I place an implant, the elasticity of the bone will actually make the implant loose inside the osteotomy. You will not get the primary stability, basically. So undersize it by 1 if the density of bone is probably D2 and D3 in between it. And if it's very hard, like D1 or in between D1 and D2, you go till the last size. You also have something known as countersink drills or countersink tools. Now, what is countersinking is you enlarge only this portion, the outer portion of the osteotomy, and then place an implant. You undersize first by 1, then enlarge the outer surface of the bone and then place an implant. That's known as countersinking. So you can use a countersinking drill also in case you want to place an implant. Fine. Now I have prepared the osteotomy by sequential drilling. Now I have selected the implant. I want to drive the implant inside. Now the implant is motor driven or hand driven. You can take a motor and then place an implant and then drive it down. You can also take a torque wrench and drive it down with the hand. Whichever system you're using, whether it's a torque wrench hand driven or it's a motor driven, the torque that needs to be given should be at least 40 Newton centimeter. That's the primary stability of an implant that needs to be there inside the bone for a good osseointegration and for a good prognosis of implant. If the implant is loose inside the osteotomy, then usually you are in a zone of probably a danger zone where the osseointegration might not be that great around the implant. So you need good amount of torque. That torque should be at least 40 Newton centimeter when it comes to the implant that is driven into the bone. The distance between the tooth and the implant should be at least 1.5 millimeters, and the distance between two implants should be at least 3 millimeters. This distance should be maintained so that you don't have micro cracks inside the bone when I am probably drilling and placing the implant. That's the scientific explanation. So maintain 1.5 millimeters at least in between the tooth and implant, and at least 3 millimeters in between the implants. I would like to place implants 0.5 to 1 millimeter subcrestal always. If you see this picture, you'll understand it is not at the crest. It is taken down by 0.5 millimeters because initially in 3 months, you will have a little of bone resorption. To compensate that, we take it down by 0.5 millimeters and then place implant. That's the whole intention. And once you're done with the placement of implant, you either place a cover screw or you either place a healing abutment. Now, when do I place a cover screw? When do I place a healing abutment? It's a big question mark again, right? I place a cover screw whenever I have doubts. As simple as that, in simple explanation. And what are those doubts? Whether my implant is stable. Now, if you see here, it's a socket. I've gone into the interradicular septum and I've engaged it. I'm not very confident, if I place a healing abutment here and close the tissue around healing abutment, some load on the implant, because it is exposed into the oral cavity, might prevent the osseointegration here. So what I would do, I would be safe. I would play safe here. I would place a cover screw, close it up completely. Watertight closure around an implant will make sure that the implant is safe. It is safeguarded inside. Now the bone will eventually form around an implant and you will have good amount of osseointegration finally. So whenever you have a doubt of primary stability, you place a cover screw and close it up. I also place a cover screw and close it up whenever I feel that there is a necessity of grafting here. Suppose the jumping distance is more than 2 millimeters. Jumping distance is the distance between the implant and the socket wall. If that is more than 2 millimeters or 3 millimeters, I would probably graft this area, put bone graft, cover it with membrane and close it down. In such cases, I would not prefer healing abutment because the graft might leach out. So these are few cases, few indications where I would probably place a cover screw and close it down. I would not place a healing abutment. These are known as healing abutments. If you see here, they're exposed inside the oral cavities. Now I've gone flapless here. I've placed implants without exposing any flap, and I've placed healing abutments. Now, when do I place healing abutments? When the primary stability is good, number one. When the distance between the opposite tooths in the opposite arch and the edentulous span is at least 7 to 8 millimeters. If I have a prosthetic space of 8 millimeters or more, then I have good interocclusal clearance here. And with that clearance, I can place a healing abutment because there won't be any loads. If the interocclusal clearance is less, then I would again think, let's not go with healing abutment. Let's go back with the cover screw, close it up. Let's play safe. So these are the few indications where I would place a healing abutment and close it down. Now here there was no need for suturing also because it was flapless. If at all you had made a incision and reflected a flap, you might have to close around the healing abutments. The advantage of placing a healing abutment in the first stage, what is first stage? Surgical stage, is when the patient comes back to you in the second stage, the tissue is already engineered. The tissue is already formed around the healing abutments. You will have a beautiful gingival cuff. We call it as a gingival cuff. And you can straight away start with the prosthetic procedures. Otherwise, in the second stage, I need to again expose the implants. I need to remove the cover screw, place the healing abutment, and then leave the patient for probably 12 more days or 15 more days for the tissue to form. There is something known as customization of healing abutments. Now, whenever I select the healing abutments, I look out for two things. One is size and one is shape. When it comes to size, I will see what is the height of healing abutment that I need to select. What is the width of healing abutment that I need to select. The height is selected from the implant to the soft tissue that is available. As simple as that. Now, if I've gone 0.5 millimeters into the bone with an implant, from the top of implant, from the platform of implant, how much of distance is the soft tissue that is present? I'll measure it probably with the Williams probe and then probably order the healing abutment according to that height. That is number one. Number two, what is the width that I need over the healing abutment? I need a healing abutment of certain width where the healing abutment should not cross over the bony contour here. Now, if I have a huge healing abutment like this, then the soft tissue becomes very friable here. It is not supported again. It becomes very thin. So that I don't need. I need a healing abutment of width, which is within the borders of the labial and the lingual contours of the bone. That's how I select the healing abutments also according to the bony contours. You can also select the size of healing abutments according to the area. Suppose I'm going with a maxillary anterior. What is the width? According to the maxillary premolar, molar. For molars, usually you need wider ones. For premolars, in between. For maxillary anteriors, again wider ones, because we need a wider emergence there. So the emergence of the soft tissue also dictates the width of the healing abutment that is being selected. Accordingly, you select and place. Now, what is customization here? Customization is when I need a particular shape, or when I need a particular width or a height of the soft tissue that is to be engineered, I customize it with a material which is known as composite. So I flow composite around the healing abutment extraorally, not intraorally. I finish it, I shape it well, I polish it well, and then place back into the implant. Now, according to the composite that I've shaped, the soft tissue is engineered. The soft tissue is formed around the composite, and you get something known as the gingival cuff. Now, the gingival cuff looks like this. Now, whenever I place a healing abutment and remove, whenever I place a customized healing abutment and remove, whichever, I need to get a soft tissue emergence around the implant in this manner. This is known as gingival cuff. Most many times, the soft tissue around the implants would be bleeding. Don't worry, it's a good sign. If it's bleeding, if it is having bleeding spot inside, it means that you have good amount of capillaries. The healing has been absolutely fantastic. So don't worry after you remove a healing abutment if there is a bleeding spot. It should be funneled like this, it should be flared up like this, and you should see the implant through the soft tissue. And this is a good amount of soft tissue that is present around the implant. Now, let's say the patient has come back to the second stage with the cover screw inside. I have not placed healing abutment in the first stage because I was doubtful. So I've placed a cover screw, sent the patient. Now the patient has come back to me after 3 months. So the first thing what you have to do, you take an X-ray and see how is the bone around the implant. If it's a healing socket, most many times the bone would not be completely filled around an implant till the platform. Sometimes it would be still healing. So don't worry about it. If it is not a healing socket and if it's a fresh bone that you've already placed an implant, now you see whether the bone is maintained or if there is any bone loss from stage 1. If there is any bone loss from stage 1, you might have to rethink again. If the implant is having any problem inside. So clinically also check how is the soft tissue around the implant, whether you have any signs and symptoms, whether the patient is telling you if the patient had any swelling, if the patient had any pain, if the patient had any pus discharge around implant when it comes to the soft tissue. If nothing is there, if there is 0.5 millimeters of bone loss around an implant, don't worry. You can open up in the second stage. Now, when I open up in the second stage, usually what we do, we take a blade, we open up the flap, we reflect the flap, open up the cover screw, and then place a healing abutment. I would suggest you to avoid that because I don't want again an exposure with the blade severing the periosteum here. I don't want that. So what I would suggest you to take is either a laser or a surgical round burr. Now take a probe. You approximately know, right, where you have placed an implant in the first stage. So take a probe, anesthetize the area, puncture the soft tissue approximately around the implant placement, wherever you've placed. And once you've punctured with the probe, take an X-ray. Now, with an X-ray, you will see how close the probe is to the implant, to the cover screw. And if you are exactly around the cover screw somewhere with the probe in an X-ray, then take a surgical round burr, open up the tissue only in that zone where you have cover screw on the implant. With this procedure, you will be actually eliminating a lot of surgical trauma in the second stage. You will not be exposing the flap too much. You will not be severing the periosteum. the blood supply, nothing. You're just opening the soft tissue around the implant and then directly placing healing abutment. So I would suggest most of the beginners in implantology to use a surgical round burr, probably expose only the area around an implant with the help of a radiograph and a probe. Electrocautery is my last thing to think, because laser is actually better when it comes to electrocautery. So if someone is having laser, yes, go ahead with laser, open up the area. Try to avoid blades as much as possible in the second stage. Try to avoid incisions and reflecting flaps in the second stage. Now, the patient is ready now. Gingival cuff is formed. Now, what is the next immediate step? I need to place a coping inside the implant to make an impression. Now here I don't have a tooth to make an impression, right? If this is the tooth, if I'm doing an FPD, if I'm giving a crown over tooth, I prepare the crown, I prepare the tooth and then make an impression. That's the regular impression technique. But here I don't have a tooth. So how will I make an impression? I need a structure like a tooth, which has to be attached to the implant and then make an impression. That structure is known as coping. So coping is a component which is used to help to make an impression when it comes to an implant. You have two types of coping. One is open tray coping and one is closed tray coping. Usually open tray coping is preferred over a closed tray coping because I can pick it up from the impression when it comes to the implant. If I pick up the coping with the impression, the advantages are multifold. And what are the advantages? I can pick up the implant position the same way. I can pick up the implant angulation the same way. I can pick up the implant depth the same way. I'm going till the implant level. All these are advantages when I pick up the coping with the impression. That's why the preferred coping for a good impression when it comes to implant is known as a pickup coping or an open tray coping. We don't use a closed tray coping because closed tray coping cannot be picked up with the impression. You make an impression over closed tray coping, remove the coping and then place back into the impression. That is closed tray. But open tray looks like this. You will have windows, either multiple windows or a single complete window or a one window according to the implants, number of implants. So you will load putty, you load a light body around the copings and then make an impression like this. Now, after the impression sets, the screw which is exposed out is loosened, is removed or loosened, and then you pick up the coping along with the impression. That's why it's known as open tray pickup implant level impression. I'm going till the implant and making an impression. I'm using a pickup coping for impression, and I'm using an open tray, which is a window, to make an impression. So this is a very good technique to make implant impression. I would not prefer a closed tray transfer coping for impression. I would prefer an open tray pickup implant level impression because the advantages are multifold, as I explained just now. And once you're done with the impression, you attach a component to the coping, which is known as implant analog. Now, analog is something similar to. What is this similar to? It is similar to the implant in the bone. So I need some component in the cast, right, which is similar to the implant in the bone. That component is known as analog. So you fix the implant analog and then pour. So till here you make an impression, you fix the analog to the coping and send it to the lab. Now lab will pour cast out of it. And once the cast is poured, I need to select the abutment also, right? It is the abutment which is more important now for the prosthetic component. Whether we make a crown over the abutment, whether we layer ceramic on the abutment is very important. Now, there are many types of abutments in the market. I'll simplify it for you. Now, if you take a stock abutment, what is a stock abutment? A stock abutment which is available from the company itself. Suppose I am using a particular company of implant. The same company will give you a stock abutment. It's a cobalt chromium abutment or it's a titanium abutment, which is available from the company. You fix the abutment onto the implant and then place a crown over it. So stock is as simple as that. You don't actually make an abutment. You utilize an abutment which is already there, which is already from the company. You just prepare a crown over it and then fix it. That's it. So stock abutment is simply which is available already. When it comes to customized abutment, customization is according to the patient's need, according to the edentulous span, according to the implant which you have placed. You can always cast an abutment. You can always mill an abutment. Now, what is casting? Casting is conversion of pattern, wax pattern into a casting. Cobalt chromium casting. So you can make a cobalt chromium casted abutment, or you can make a milled abutment. I take a metal, I mill it and probably place it into the implant. The abutment which is available from the company to make a casted abutment is known as UCLA abutment. Now, UCLA is a plastic abutment which is given by the company with a cobalt chromium base. You just have to send it to the lab. They will make a casting out of it and they will send back to you. You just have to fix it and probably make a crown over it or screw retain restoration. Milled abutment is you scan it, you send the scan data to the lab will mill it. The lab will mill the metal and give back to the clinician. So selection of abutment is very, very important, whether you use a stock abutment, whether you use a casted abutment, whether you use a milled abutment. So that you can take a call as a clinician. There is no hard and fast rule that you have to use this year, you have to use this year. According to the clinical aspect, you need to take a call and probably select the abutment and then place it. There are three types of prosthesis in implantology. One is cement retained crown, one is screw retained crown, and one is screw cement retained crown. Now, when it comes to cement retained crown, see this picture, you'll understand a simple thing. There is an implant, there is an abutment, and there is a crown. So once the osseointegration of implant is done in bone, I fix the abutment into the implant. A crown is made separately and then fixed over it and luted over it. So you will have three components in cement retained crown: implant, abutment, crown over the abutment. That is known as cement retained crown. What is the disadvantage of it? Now, if I cement this crown over the abutment, can I retrieve it if there is a problem inside? I cannot retrieve it. I can't use a crown remover and then start removing the crown because it's an implant. What I have to do, I have to cut it down if there is any problem, because I don't have an access to the abutment here. It is just luted. So cement retained crowns are usually not used very much in implant practice, except in the anteriors where the screw access hole is labial. What do I mean by that? If I have placed an implant to labial, if I have not placed the implant probably in a palatal direction to labial, the implant opens up labially. The future prosthesis will have a hole, screw access hole, which is labial in position. In such position, in such instances, circumstances where I cannot give a layering of ceramic over it, I cover it up with a crown. That is known as a cement retained crown. So in such cases, I use a cement retained crown. Otherwise, in ideal cases, I would prefer something known as a screw retained crown. Now, if you see here, there is an access here. The ceramic layering is done over the abutment and you have an access to the screw here. So I can, whenever there is a problem, I can go into the screw, open up the screw, remove the whole prosthesis as one unit, and probably take care of the complications. So a cement retained crown is given only in probably where there are complications, where there are mishaps or errors. A screw retained crown is an ideal choice where you have an access to the screw and you can open up or tighten whenever you need. That is more important to understand. Now, let's say that the prosthetic space is very, very less. Screw retained is an ideal choice. In such cases also, because for a cement retained crown, the space is very less and the cement retained crown might dislodge frequently because there is no ferrule basically for the cement to stay on inside the crown. So in such cases also screw retained crown can be an option. Now this is known as SCRP, screw cement retained prosthesis. If I want to give a cement retained crown and then convert that into a screw retained also, what I would tell the lab, I would tell the lab, create an access hole in the crown and give it back to me. Then I will cement it. Now, once I cement it, what will happen? All the cement will come out here and here. I can remove all this excess cement here and then fill it up with composite. Now, whenever I have a problem with the cement retained crown, I can always remove the composite here, remove the Teflon that is there inside the abutment, straight away go into the screw, open up, so that the whole prosthesis is lifted out from the implant. It is taken out from the implant. This is known as screw cement retained crown. A cement retained crown is changed into a screw retained crown by just incorporating a access hole on the crown by the lab. So this is one modification, a good modification, which is there in implantology. If you want to give a cement retained crown, which is again a screw retained, that is known as SCRP. Now, what are the differences between a single implant and multiple implants? Now, when I talked about single implant, I said I use a coping which is known as open tray pickup coping, right? If I have two implants and if I place two copings here, when I pick up the copings with impression, there will be a mild flexure, there will be a mild rotation of the copings here when I remove it. That mild rotation is stopped when I splint them like this. This is known as a jig. I just put floss around, I put patent resin around and make them a rigid splintered jig. This is known as an impression jig or a transfer jig. Now, when I make an impression now, what will happen? This will not move, this will not move. The same position is picked up in the impression. So, first important difference between a single implant and multiple implants is in single implant, I usually don't make an impression jig. I usually don't make a transfer jig. I make only a transfer jig when there are multiple implants, more than one implant, so that I don't have a movement when I pick up the copings with the impression. That's the first point. Second point is, once I'm done with the impression and once the impression reaches the lab will pour the cast and make one more jig over the cast like this and send back to me. To me means to the clinician. This jig is known as verification jig. Now, what is verification jig? This jig is again kept into the implants and verified whether this is passive or not. What do you mean by passive? It should neatly go and sit into the implant without me forcing it to sit into the implant. That is known as passivity. So a transfer jig is followed by a verification jig in the lab. And then I take it into the implant, I tighten the screw one by one, and then see whether the jig is passive. If this is passive, let's say, it means that my impression was correct. The way I picked up was correct. If this is not passive, let's say, if this verification jig is not fitting into the implants, then it means my impression was bad. My impression was not accurate. In such cases, I would split up inside the oral cavity, make this passive, and probably join this again with the patent resin and send back to the lab. This is known as modified verification jig. I modify it intraorally, send it to lab so that lab can modify the cast according to the modified jig and start the prosthetic procedure. When it comes to a full arch, when it comes to cement retained implant prosthesis, you will have something like this. You will have multiple abutments into the implant and you will have an FPD. That's all. There's nothing to actually think more. Abutments in implants, a bridge over the abutments. That is cement retained. Now, when it comes to full arches, I would not suggest this. I would not suggest a cement retained bridge in full arches. Why? It is not retrievable, number one. It might be passive, but it is not retrievable. If I have some problem here or here, the whole prosthesis has to be cut down and removed. I cannot just remove the prosthesis like that. But when it comes to screw retained, it's something like this. Now, if you see here, there are multiple access holes here. So whenever I have a problem with one of the implants, let's say, then I can go into the screws here, open up all the screws and remove the prosthesis. That is known as your screw retained implant prosthesis. So I would suggest screw retained prosthesis for a full arch and not probably a cement retain, or you can go with a screw cement retain. Make a cement retain prosthesis, tell the lab to incorporate holes wherever the abutments are opening up. That becomes a passive prosthesis with retrievable prosthesis. Both can be achieved with SCRP, screw cement retain prosthesis. The difference between here and here, see here, you have abutments and a bridge. Now, when it comes to here, screw retain, you don't have individual abutments. Kindly observe that you have a framework. What is a framework? It is completely joint. It is completely splintered. And ceramic layering is done over the framework. So you have only one unit here. Framework, ceramic layering. In cement retain, abutments and a bridge. So this basic difference, if you understand, it is very easy for you to actually, simulate it clinically also whenever you do the work. This is very, very important. Most of the implant failures, most of the screw failures happens because of poor occlusion, happens because of malocclusion. If you see here, whenever I give an implant crown, I make sure that the implant crown in the posterior region is infra-occluded by at least 28 microns or 40 microns. Now, why do I do this is, whenever the patient bites on natural teeth, the natural teeth have a compression because of PDL. Whether it is this tooth or this tooth, both will go down by around 28 microns. When it is an implant crown, it is not going down. It is stuck because it's osseointegrated. It does not have a compression inside. So what will happen? This will act as an interference always. Whenever the patient is chewing, this will stick out. So tell the lab, infra-occlude and give me. So that when I place the implant crown, whenever patient is chewing like this is already infra-occluded by 28 microns. And when the patient bites very hard, these three will become equal. Now, if you see here, there is no mark on the implant crown. When the patient is biting hard, if you can see, there are marks on the implant crown as well, creeping up. It means light closure, there should not be contact on the implant crown. Heavy closure, you should have a contact on the implant crown, which is lighter. So remember, posterior implant crowns should be infra-occluded by around 28 microns. Anteriors, kindly avoid the contact, whether it is a static contact or a dynamic contact, whether the patient is moving in protrusion or late protrusion, whether the patient is biting on in maximum intercuspation, no contact on anterior implant crown, zero contact. Whether here, whereas here, in static contact, light closure, no contact, heavy closure, light contact. In protrusion, late protrusion, no contact on the implant crown. So in dynamic movements, the implant crown has to be free from contacts. Whenever there is an implant in canine zone, do not give canine guided occlusion because the implant will be under stress. It might fail. Always spread it to the next premolar, which is known as partial group function. So whenever you have implant in the canine, spread it to the other teeth, which is known as your partial group functions. Don't give canine guided occlusion. The implant might fail. In full arches and full mouths, give a mutually protected occlusal scheme with few modifications as I just explained. Anterior should be avoided completely from contacts or give very, very grazing contacts of 8 microns. Posterior should have at least 8 to 12 micron static contacts. These are the articulating papers with which you need to check. Anterior protrusion should give posterior disclusion. Lateral movements, you should have a group function. You should not have a canine guided occlusion. All teeth should take up the load because it's implants. It is not a natural tooth where you have periodontal ligament. Remember, this is the difference. So shallow occlusion is the key. Don't give a steep occlusal scheme with implants. Keep it as flat as possible so that you don't have lateral stresses, lateral forces on implants. It is only the longitudinal or the compressive stress that is falling. Always give a prosthetic torque of 25 newtons or 30 newtons. Don't give under torque. Don't give heavy torque. Don't give 40, 50. The screw might stress out. The screw might break also sometimes. Don't under torque it because it might become loose. So company recommended torque is something which I would suggest. Don't give a hand torque. Always use a wrench. Use a torque wrench, set the value, and then give a prosthetic torque. Don't give cantilevers like this for single implants. You can give cantilevers if it's a full arch or a full mouth because it is splintered with multiple implants. With single implants, with 2 implants, don't give a cantilever. There will be screw loosening like this. Always maintain the size of prosthesis as less as possible. Don't give huge crowns over implants. Don't give cantilevers, whether it's a horizontal cantilever or a vertical cantilever. Kindly give smaller crowns around implants. Try to give occlusal contact at the central fossa as much as possible because that's where the implant is there. So try to give longitudinal forces to the implant. Don't give tensile forces. No contacts on marginal ridges, no contacts on inclines, only at the central fossa or around, a little around the central fossa, 1 millimeter. Never anywhere else on the implant crown. So these are the takeaways which I've explained in a sequence. Now, to summarize you all, whenever you have an implant case, first plan the prosthetic position. Place the implant according to the prosthetic position. Once the implant is placed according to the prosthetic position, then you plan the prosthesis according to that position. Whether it's a cement retain, whether it's a screw retain, or whether it's a screw cement retain prosthesis. Try to avoid cement retain prosthesis as much as possible because it is not retrievable. Either select a screw retain prosthesis or a screw cement retain prosthesis because you have an access to the screw. You can open up at any time. You can close it at any time, whenever you want, when there is a complication. So these are my contact IDs, and whenever you want to contact me regarding any case, regarding any complication, you can drop down your queries here and I'll be free to answer them at the earliest. Thank you so much. And this is the implant program which is conducted by Safe Dental very soon. Probably in December it's starting with the surgical and prosthetic modules. I hope you all got engaged with the presentation and I hope all of you can carry over a few points. I tried to simplify as much as possible within the period of time we had. Thank you, Shanuf, and thank you, Safe Dental Updates.
Thank you so much, sir, for sharing your knowledge and expertise when it comes towards understanding implantology. So definitely many of us would depart this discussion with amazing takeaway points. So let me just share my screen as well, just to show the, okay, yes. Yep. So if you really want to learn and perform implantology, we do have this exercise, as sir mentioned, in our implantology program, which consists of 2 phases. One is a surgical phase and another is a prosthetic phase. So the surgical phase is going to be held on 16th, 17th, and 18th, which is going to be Friday, Saturday, Sunday of this December 2022, and prosthetic phase on coming 4th and 5th February 23. So this program will have a deep understanding of implantology by giving hands-on exercise on models, live demonstration on patient, as well as you will get a chance to perform this treatment live on patient as well. So if anyone is interested, you can always contact the mentioned numbers to register. Even the fees also are been can be done through installments. So before, yeah, I would like to share another poster as well. Yes. So even I had mentioned in our introduction that Mahi sir used to conduct a full mouth rehabilitation workshop as well. So that is going to be held on 13th, 14th, and 15th of this January 2023. So once again, thank you so much, sir. It was very informative. And thanks to all the doctors who have participated for this webinar. And I hope all of you will depart this session with a positive, confident manner. So thank you so much, sir. It was very informative, sir.
Thank you, Shanuf.
Okay.
Take care, all of you. And if you have any doubts, please pass on to Shanuf. He will pass on to me, and I would probably reply to all those doubts you had.
Yes, sir. It'll be clarified in the social media platform.
Sure.
So thank you so much, sir. And thank you all, and have a great night.